Our next speaker is Ambassador Deborah Birx. Dr. Birx has dedicated her life to improving the health of others around the world through the development of diagnostics, therapeutics, and vaccines, and critically, the use and integration of big data in pandemics around the globe and promotion of healthcare security. She has also served as White House Coronavirus Response Coordinator, bringing together years of research and development experience in diagnostics, therapeutics, and vaccines, along with her real-life experience combating pandemics. At this point, I would like to turn the floor over to Dr. Birx, who will present on the impact of long COVID on the United States. Dr. Birx, you have the floor.
Thank you. And thank you, Dr. Kavanaugh, and all of the presenters today for staying engaged 4 years later. I think if you just step back, most Americans and most people around the globe believe that when the pandemic was declared over, that it was no longer a problem. It remains a significant problem. And I appreciate everyone who remains completely engaged in this issue, because this is a significant problem all across the globe. The good news is over the last 4 years, we've had some really excellent publications about the depth and breadth of long COVID. But I would say the media, most of the medical world around the globe really has been continuing ignoring the consequences of COVID. And just as you said, Dr. Kavanaugh, mild disease can lead to long COVID. I think this was a real misinformation out there that long COVID only was in significant hospitalizations and people who had spent months in the hospital and were in rehabilitation. Now we know that there is medium COVID that may last 2 or 3 or 4 months. There's long COVID that, although the symptoms attenuate, many symptoms are still found after 2 years. We have good documentation of brain inflammation and destruction of microglial cells. Those are the cells that protect our brain cells. We've seen the late cardiovascular impact and the number of heart attacks and strokes, as well as increasing diabetes. So this is not just about acute COVID and acute hospitalizations, which continue to occur. And I'm going to talk about that at the end, because I think there's real age discrimination at play, because we're ignoring the fact that this disease continues acutely to be deadly to those particularly over 70. Now, going across the internet and talking about misinformation, there is really quite an excellent amount of information on the NIH website and other sites, really for patients and general information that talks about what causes long COVID, makes it very clear that children can get long COVID, has a great picture of how the depth and breadth of this virus and impacting these different areas of our bodies. So if you go on the website, you click on any one of these hotspots, it will go through all of the symptoms associated and have been reported for long COVID in these different areas. There's also been some excellent epidemiology published, as well as the impact of vaccines on long COVID. I just want to make it clear, the reason these waves come every 4 to 6 months across the globe is because natural immunity and vaccine immunity also wanes. So these vaccines are not durable, and the way that we usually look at vaccines in long-term protection against infection. And that is what's leading to the breakthrough infections, but also the breakthroughs of long COVID. So this was an excellent study published, bringing together all the data, recent data published in 2022, really looking at all of the issues of long COVID and showing that it's about 7% or 18 million Americans with these symptoms. But you can see, even in those who were fully vaccinated but not boosted, a significant risk, and really actually the highest adjusted prevalence was in the fully vaccinated, not boosted, but of course also that represents the largest population in the United States. So, and you can see though that significant long COVID, even in those who have been boosted. Those who've never been vaccinated despite prior infection also are at significant risk for long COVID. There's an excellent study that pulled together, and I think it's one of the most comprehensive, that followed patients over time about what the symptoms are and the symptom complex of long COVID 2 years after acute COVID. And you can see the number one symptoms in over 15% and often in the 20 to 25% range is cognitive dysfunction and difficulties concentrating, high levels of fatigue, anxiety, and leading to depression. This is really important because it affects the work life and the growth life of our children and our young adults, as well as adults in every age group. If you look at the symptom complex and you look at the light blue lines over 24 months, you have 35% of the respondents still reporting high levels of fatigue, significant anxiety, depression, insomnia, difficulties concentrating, amnesia, still having loss of taste and smell, and dysautonomia. And all of these symptoms are really critical, but the complexity of the system leads people to question whether it's long COVID or not. But I think this data is really making it clear that there is a symptom complex. Now, Eric Topol and a team put together all the major findings of long COVID. This was just recently published. They reviewed the literature and put this together, both talking about initial infection and risk of long COVID and medium COVID, as well as breakthrough infection. It talks about, and this article is really terrific. I really ask you to pull this and look at it. It's very important for your patients. Again, goes through all of the symptoms. Now we have it on the NIH website. We have it clearly in people who've been followed over time, and we have this summary in this article. But with initial infections, we still have that high risk of pulmonary emboli, cardiac arrest, cardiac failure, death, stroke, and diabetes. This is still killing a large number of people around the globe, despite the fact that it's not being actively reported. We have people today in the hospital and dying of COVID. We also have this dysautonomia and this chronic fatigue in long COVID. I wanted to call your attention to breakthrough infections. The previous people have been previously vaccinated, still having pulmonary and coagulation abnormalities, as well as the cardiovascular and neurologic. So again, showing, as Dr. Cavanaugh said, we have tools, masking, vaccines, and mitigation, but really the only way you can prevent long COVID is to prevent infection. Also in this article, it talks about the potential mechanisms, and those are becoming clearer and clearer, that there could be and probably are pockets of persistent infection of SARS, but also reactivation of EBV. I'm seeing a large number of patients with reactivations of EBV and persistent EBV, which leads to further immune dysregulation. We talked about the important role of the gut and this issue of serotonin. There's also evidence of autoimmunity and reaction to COVID infection itself. The clotting abnormalities and the inflammation caused in the cardiac vessels that have been well documented, and then the neurologic dysfunction due to active infection or the side effects. Also in the paper, they summarize the treatment. And as Dr. Cavanaugh noted, there are experimental treatments, including Paxlovid, being utilized to see if it has an impact on the rate of long COVID or resolution of long COVID. But you can see that a lot of these are case reports and pilot studies. So much more work has to be done in this field, and NIH is investing in these long COVID studies. Now, I think what's really concerning to me and has been concerning for the last almost 4 years as the loss of taste and smell to me very early on in 2020 illustrated to me that COVID and SARS-CoV-2 was very different than other respiratory diseases because it must be impacting the brain. And it's creating these neurologic events, which a lot of people discounted. Oh, I just lost taste and smell. That is a significant issue and illustrates this ability of SARS-CoV-2 to actually infect and impact the human brain and memory. And part of this is really becoming very clear that they can cause cell death, both an infection from the eye, the lung, the nasal cavity, and its invasion that causes immunologic dysfunction, but also neurologic dysfunction. Leading me to be very clear, COVID is not the flu. And by linking the COVID shots to the flu shots in the fall is creating that sense in the public that, oh yes, this is just something that happens in the winter. It's like the flu, it's seasonal. COVID-19 is not seasonal in that it has both a summer and winter wave. This is evident both in the northern and southern hemisphere. It will never be the flu because its long-term and medium-term impact and the incidence of other diseases that it is causing. Also, I very much worry about what's going to happen in 10 years. So we shouldn't be blasé with the public acting like we know everything that this virus can do. I think many people were surprised about the depth and breadth of SARS-CoV-2 impact on the arteries and plaques and heart attacks and microclots. But I think they're also surprised at long COVID. But what if the brain inflammation and the damage that occurred now or occurring in long COVID leads to early onset dementia? We don't know what long COVID can evolve to because we only have 4 years experience. And so I think it's really important as public health officials, as far as the media and others, to really make it clear to the public what we know and what we don't know, so that 10 years from now, there is not further backlash with people coming forward and saying, why didn't you warn us? Why didn't you warn us that you didn't know everything that this virus could do? Also, there are people dying every day from COVID-19, which we completely ignored the summer wave. We didn't provide vaccine boosting to those across the South. We know that these vaccines are not durable, both in protection from infection as well as protection from hospitalization and death. And so really ensuring that all Americans or all people around the globe are warned about when they are seeing uptick, and whether if you're following wastewater, so that they know to get vaccinated when those waves are coming. We did not provide any protection against the summer wave. Now, I realize a lot of Americans live in the Northeast, and so telling people to be vaccinated in the fall makes sense for them, but it does not make sense for the people in the South. Again, I know we concentrate a lot on the social determinants of health. I want to just remind people all the time that this disease impacted population differentially and different races and ethnicities, but the population that was impacted the most is the Native American population within the United States. And continues to be impacted is individuals, particularly over 75. The case fatality rate for people over 85. Now, admittedly, just to be very clear, this only does case fatality around people who are cases. And so if people over 85 are not tested, we don't know if they had COVID. But if you look at all of the case fatality rates in the United States of people over 85, their case fatality rate is 16%. And overall, we have lost 8% of the American population over 85. So we know that pandemics do create inflection points. I've worked on pandemics for 40 years, whether it was HIV, whether it was Zika, whether it was Ebola, all over the world. And these pandemics do create inflection points. They do create a new awareness that allows us to change how we work, both in the healthcare industry and in the community. And we do have new tests, and we have the home diagnostics, which is very new for infectious diseases. We also have new tests for rapid flu, COVID, and RSV at clinics, which is critical because we're entering a time where these will be overlapping this year. Last year, they were serially. The years before, they did not come together, but this year they will, and I'll spend just a moment talking about that at the end. We've expanded telehealth around the globe. I think the innovation of Hospitals Without Walls and sending people home early with monitoring is really helping our patients who can get back home into their more comfortable environment, but still be actively monitoring. And access to real-time data for the public and its reporting by the media was really critical in COVID. We should learn that could be utilized for all infectious diseases to warn communities what infectious diseases are being seen that week. And so parents understand what's circulating in the elementary schools and what's being seen in the pediatrician's offices and what they have to be concerned about. Because many Americans live in multi-generational households, and that is critically important for us to continue to understand that as these viruses come into the household, often detected because young people are asymptomatic, the elderly in that household can get quite sick, and everybody wants to protect their grandparents, their great aunts, their people in their household. So if they're giving information, I do believe people are empowered to change. And I've seen that all over the globe, and we have to trust people to make the right decisions if we give them the right information. We know that rapid testing can decrease community spread. I've seen this in universities over and over again, in hospitals and long-term care facilities. So what's going to happen this fall in the United States and probably the Northern Hemisphere in general is we will have overlapping RSV and COVID. And to just show you the impact of what I believe will happen, obviously, we're going to have serial absenteeism of workers because of sick children and sick elderly that get hospitalized and sick workers for nearly 4 months. And we need to start planning now at all levels to understand that impact and be prepared. We know what happens when hospitals get beds full. So let's start thinking about how we're going to triage in emergency rooms and clinics, because we will see these diseases overlapping. And please, you cannot guess what you have. Flu-like illness looks alike no matter where you are. COVID, RSV, parainfluenza, flu, adenovirus all look very similar, and you cannot tell by symptoms. Although I am a bit outraged, it doesn't seem like many people are outraged that we have lost COVID therapeutics. We only have antiviral now. And what was really protecting many of our individuals undergoing chemotherapy and the true elderly was long-acting monoclonal antibodies. We lost them over 1.5 years ago. We have not replaced them. We have not worked on more durable vaccines that could really last through multiple surges. And we haven't really defined how frequently the elderly should be vaccinated. Certainly when you see these surges coming every 4 or 6 months, and we know that their ability is limited, we should be immunizing more frequently. And we're not using the limited data that we have in a proactive way to really empower people. Now, I just want to show you, we're talking about these diseases becoming endemic. I call your attention to the CDC surveillance system that says that we have been over the epidemic threshold for respiratory diseases for almost 4 years. Yes, a few months ago, we dipped almost to that line, but we've been back up above that line and that baseline, that seasonal baseline, for almost the entire last 4 years. And so I don't care what terminology you use. All of these respiratory diseases are significant and having a significant impact. And we do have the tools to mitigate against acute infection and therefore chronic disease. Just to take you through our most current data, we do have limited wastewater data now because of this contractual issue with the CDC. And so going into the most vulnerable period, we will not have adequate wastewater data. But before most of the wastewater sites went down, you could see that wastewater was detecting rises once again in the upper Midwest, and the South was starting to increase again. This will be followed by a significant increase again in the Northeast over the next 4 weeks. We had a change in the variant to EG5. And just to call your attention, what we know triggers the fall to winter wave is the cooling in the Northern Plains states. It was warm in the Northern Plains states until a week ago. This is the weather this week in Fargo, North Dakota. So you can see they are below freezing most of the days of the week. And that is what brings people indoors and triggers the next surge. And the wastewater shows that identically. So you can see in these more populated counties of North Dakota, rapid rise in the wastewater. So what should be happening right now? Right now in North Dakota, all of the people who are vulnerable should be getting alerted that now is the time that they have to be revaccinated, but also know that there are people, particularly among the elderly, because their immune system declines just like our knees and our rest of our bodies, the immune system deteriorates and is not as responsive. And so they still may not be adequately protected. And so warning people who are in multi-generational households and nursing homes for proactive testing and really getting ahead of this pandemic and really ensuring people get rapid. Again, our only tool for treatment is Paxlovid. So they need to know that they're infected so that they can go on medication. You wouldn't really know. This is still being covered in the New York Times, and I greatly appreciate that they have not taken down their COVID information as most other people have. But let me be very clear, daily hospitalizations, by the time your community is seeing a rise in new hospital admissions, your community spread is over. Basically, the virus has spread through your community in such a dramatic way that mitigating now is too late. So this is helpful for the hospitals, but not helpful for prevention. Where are we with RSV? If you remember last year, RSV was early, but RSV is just starting in the South right now, which means it will peak in December. So RSV will be later this year. This is what's happening already in the South. And we have significant hospitalizations of children across Texas and North Texas. But you can see, and it's very subtle, but you can see RSV detection is rising across the United States from the Midwest to the Northeast to the West. And it's these subtle rises. You can see that leads to that rapid peak, showing that this infectious disease, this respiratory disease, lasts about 6 to 8 weeks. And that's the same with flu, and that is the same with COVID. So what's happening with flu, you can just see if you look at the right-hand graph, those little red starting lines show us that flu is starting, the season is starting. Again, flu was earlier last year. It looks like flu will be approaching a normal seasonal timeframe. What does that mean? That means that we'll see cases rising rapidly post-Halloween and peaking in November and December. Now, is this sounding overlapping? Now I'm talking about RSV and flu peaking at the same time, and COVID cases being triggered in the Northern Plains states that will move through the country, again, triggering a wave in that November, December timeframe, showing you that vulnerable Americans, whether they are children under 2 or whether they are the elderly, we're going to have all of that come together in the November, December, January timeframe. And so this is where flu is today. As you know, it starts in the United States in the South, moves upward, and this is what we're beginning to see right now. I just wanted to mention briefly that there are articles coming out now about how different infectious diseases and respiratory diseases, this comes from the UK, can lead to many of the symptoms associated with long COVID, although the duration has not been the same in the United States. And so for the next speaker, I'm going to end a bit early so that you know that you're prepared. We know vaccination and boosting is critical, but it's not enough. It is a tool to prevent infection, but it's not absolute. It's not 100%. And so even though you've been vaccinated, you can transmit COVID in an asymptomatic way to your vulnerable family members. And they are susceptible because their protection against hospitalization wanes several months after being vaccinated and boosted. And so, yes, the vaccinating right now and the boosting right now will be helpful for the Northeast, but it was not helpful for those who suffered and died in the summer from COVID when we had the summer wave. Proactive testing becomes really critical because the elderly often do not develop symptom complexes early. And so you can be past the 2 days for flu antivirals or the 5 days for Paxlovid starting. And even with Paxlovid, the earlier you started, the bigger impact it has in preventing severe disease. And so getting people diagnosed early, particularly those who we know have blunted immune responses and therefore do not develop high levels of fever like children do, particularly those over 75, is critical. As Dr. Kavanaugh mentioned, surgical masks are not appropriate to protect against both transmission and infection, and 95s and KN95s are absolutely required. And communication with clarity is important because people will make the right decisions for themselves if they're empowered with information. I saw that with Zika, I saw that with Ebola, and I've seen that with HIV. Give people the information that they need, and they will make decisions that protect themselves and their family. Next generation vaccines and therapeutics are needed, and therapy for long COVID is absolutely essential. So thank you for your time and attention. And I want to thank the other speakers and Dr. Kavanaugh for bringing this together.
Well, thank you very much. We do have one question that you might want to answer because we have a little bit of time. Does long COVID lead to irreversible sequelae?
Well, again, that's hard to answer. We have people now who are many years out from acute COVID and still have a constellation of long COVID symptoms. So as I showed in that graph, going out 2 years, you can see how many people still have all of those symptom complexes. And so although there are less, and people are like, well, they're less over time, so maybe they'll go away completely. We can't say that as health practitioners, because as long as there are people who still have symptoms years later, we cannot tell the public that long COVID is a transient and controllable outcome. We need to be very clear and say we have patients that still have symptoms as long as we've been following them. And so we cannot say that long COVID resolves on its own. Hopefully therapeutics, and that remember, the therapeutics are going to have to be comprehensive, and they will never bring back the people completely to full health that had a heart attack or stroke because of the microclot. So the disabilities that we're creating by ignoring these COVID waves and not informing the public about their risk is going to be all on all of us as health providers and public health officials. Because the more we don't provide clarity about the risk of acute and long COVID, the more people 10 years from now will accuse us of not being effective public health practitioners.
Well, thank you very much.